Hello, my name is Dan Svenson. I'm here to talk about chronic obstructive pulmonary disease. With this presentation, we'll go over a case study, also look at some typical findings, risk factors, and how to manage COPD. So we'll start with our patient. This is Geraldine Jones. She's a 70-year-old female with COPD presenting for a follow-up from a recent hospital admission. She was diagnosed with COPD approximately 10 years ago, and as of lately, she's been getting admitted to the hospital about every 6 months for exacerbations. She feels she really would like to get better control, so she does not need to spend much time in the hospitals as she has as of lately. And this is Geraldine's current history. She has a prior medical history of COPD and hypertension. Otherwise, she's been fairly healthy. She currently takes medications. She's taking Advair twice a day, Spiriva daily, and for hypertension, she's taken 10 milligrams of lisinopril and 50 milligrams of metoprolol extended release, and she's also taking a baby aspirin daily. She doesn't have any known allergies. Her social history, she lives alone. She's a former smoker, quit about 2 years ago, and does have a 75 pack year history. She tries to stay active as much as she can, but frequently feels she gets short of breath and has to stop just to catch her breath. Her family history, her husband is deceased at age 68 from cancer. She has 2 older children that are healthy to the best of her knowledge and live away. Her mother is deceased and also had hypertension and high cholesterol, and her father, who is also deceased, had cancer and hypertension. These were her lab values at the time of discharge from the hospital. Nothing stands out as being too abnormal here. So first, let's talk about COPD. What is it? It's a lung disease characterized by chronic obstruction of lung airflow that interferes with normal breathing and is not fully reversible. Can be caused by a mixture of small airway disease, so it's obstructive in the bronchioles, or it can be also parenchymal destruction, which is typically seen in emphysema. Excuse me. Chronic bronchitis and emphysema are no longer used as diagnoses. These are all encompassed by the current diagnosis of COPD. And COPD is the 3rd leading cause of death in the United States. And when we look at this, the difference between chronic bronchitis is in the bronchioles, you'll have the inflammation with production of very thick, sticky mucus, whereas with emphysema, you have the destruction of the lung tissue at the alveoli, so you get a lot of air trapping and gas doesn't exchange very well. So what are some risks for COPD? Well, the number one risk is tobacco smoking. That is the number one cause, as we've seen with COPD. We also have some environmental exposures, which can be indoor air pollution, typically seen in industrial settings, but also some outdoor air pollution. Some other risk factors can be associated with the person themselves. It can be genetic abnormalities, abnormal lung development, or accelerated aging, but these aren't typically seen as much as the previous 2 mentioned. So some common symptoms. Typical symptoms include a cough, usually worse in mornings with that can be productive in small amounts of colorless sputum, breathlessness or feeling short of breath, and also some wheezing, particularly during exertion or exacerbations. So getting back to Geraldine, this is her current exam, her vital signs. She's got a blood pressure of 138/88, a heart rate of 85, respiratory of 26, um, temperature of 37.2. Her current weight is 95 kilograms, and she has a height of 5'9", and her current pulse oximetry is 93%. Review of symptoms. She does feel a little short of breath with a chronic non-productive cough, some fatigue, some activity intolerance. She appears to have a mild respiratory distress after walking down the hall to the exam room. Her skin is warm and dry, no obvious rashes. HEENT, normal cephalic. She's got equal and round reactive pupils, moist mucous membranes, no lymph nodes noted to be tender or swollen. Lungs, she definitely has some tachypnea, followed with a prolonged expiratory phase. Decreased breath sounds were noted in the lower bases of the lungs, but she does not have any rales, rhonchi, or crackles, or wheezes are not really notable. Cardiovascular, she's got a regular rate and rhythm without murmur, normal S1 and S2. Abdomen is soft, non-tender. She does have positive bowel sounds. No problems with GI or GU, no clubbing, cyanosis, or edema noted on the extremities. She does have good, strong pulses peripherally. And she is alert and oriented ×3 with her cranial nerves intact, normal mood and affect, and equal reflexes. We did do a quick pulmonary function today. So these are her current values. She has an FEV1 of 1.3 liters. And in this particular patient, the predicted value would be about 2.7 liters. And we also have the values from her last admission. So you can see from some of the values, there is a slight improvement from her last admission, but still not overall, still not in a good place right now with her pulmonary function. So what are the goals with managing COPD? The biggest thing is to assess COPD. We need to determine the severity of the disease, including the severity of airflow limitation, how it's impacting the patient's health status and the risk for future events. And we also got to look at comorbidities, as they can frequently cause more problems in the COPD patient. So for classification of severity of COPD, we look at the gold standard. And basically what we do is we look at the FEV1 divided by the FVC, and anything that is less than 0.70, that is what we define as a patient with COPD. Then we look at the FEV1, and we can classify them in one of these various stages, gold 1 through 4, increasing in severity. So FEV1 greater than or equal to 80% of the predicted value for FEV1. Stage 2, which is 50% to 80% of the predicted FEV1. Gold 3, which is severe, 30% to 50% predicted. And very severe, which is anything less than 30. Some additional assessment tools that are available for COPD is you got the COPD assessment test, which is this is a test that the patient can fill out prior to a visit. And basically, you have about 8 questions or 8 answers here where they can scale anything from 0 to 5 on how they feel each of these affect them. Or you can use the Modified Medical Research Council's dyspnea scale. This one's just an easy one where they can read various statements and choose which grade applies to them most likely. Then the gold standard also has the ABCD assessment. Basically, what this does is it takes a look at that they are truly a patient that is affected by COPD with the FEV1 over the FVC of less than 0.7. You can look at, then it takes this staging of gold 1 through 4 based on their FEV1. And then we can determine a grade of where the patient currently is existing. So we take the exacerbation history. If they've had 0 or maybe 1 recent exacerbation but did not lead to hospital admission, that would put them in the grading scale of A or B, or the exacerbation history of having 1 or more exacerbations leading to hospital admission, or having 2 or more exacerbations puts them in the higher or the lower grades of C or D. Determining which side of those grades that we go, you can use the MMRC scale or the CAT scale score, whichever one you choose to use. But in this case, it would determine if it's MMRC of 0 or 1, you can get an A or a C, or if it's 2 or above, it puts you in a B or a D score. So what does this mean for Geraldine? So basically, when we look at this, her FEV1 was 1.3 with a predicted of 2.7. She's at 48% of the predicted value. So that makes her a gold 3 stage of severity. And we did do a quick MMRC scale for Geraldine, which she felt she was about a 2. So that pretty much points her in a category with the recent history of exacerbations of 2 or more. That would put her in a grade score of D. So she's in group D. So managing COPD, what are our objectives here? So how do we do it? So smoking cessation is key. This is the number one means of managing COPD in an easier fashion. We also have pharmacological therapy that can reduce symptoms, reduce the frequency and severity of exacerbations, and improve health status and exercise tolerance. The biggest thing for any type of pharmacological therapy is it needs to be individualized to the patient based on severity of symptoms, their risks for exacerbations, side effects, comorbidities, and drug availability and cost, and what the patient's response, preference, and ability to use them are. Also, it is highly recommended that anyone with COPD receive vaccinations for both influenza and the pneumococcal vaccination. Long-term oxygen is recommended for any severe resting chronic hypoxemia. And also they've found great value in pulmonary rehabilitation to help manage patients with COPD. So pharmacological treatments, what are some options? Like we reviewed in class, we've got the short-acting and long-acting beta-2 agonists, bronchodilators. We've also got the anticholinergics. These are also, some are short-acting, some are long-acting. We've got the xanthine derivatives, which is the theophylline. We've got the phosphodiesterase 4 inhibitors, inhaled corticosteroids, oral steroids, and then we've got the combinations of both the beta-2 agonist with an anticholinergic, or we've also got the beta-2 agonist with a corticosteroid combination. So what are the recommendations as far as medications go for COPD? Well, looking at the gold standard, based on the group that patient is determined to be in, they give you some recommendations as far as what medications work well for patients in that particular group. So depending on the group, would elicit what medications you would give. So we'll take, for example, Geraldine. We determine that she's in group D. So as you can see here, we'll look at group D. Down at the bottom is where you would start. So you could start with a long-acting anticholinergic. And as exacerbations further, you can escalate care to a long-acting beta agonist with a long-acting anticholinergic. Now there is some leeway here. You could go with a long-acting beta agonist or inhaled corticosteroid, depending on what is working for the patient or preference. But as symptoms persist or exacerbations occurs, when you want to further escalate this. And looking at this, the green highlighted treatments are the preferred treatments. And then as you go and escalate, you escalate to the middle here in the green, which is the triple therapy of the long-acting beta agonist and the anticholinergic with an inhaled corticosteroid. As further exacerbations occur, they do have recommendations for some additional medications. So to the top left, you can consider roflumilast, which is the PDE4 medication. This is the recommendation for anyone with an FEV1 of less than 50% of the predicted value in patients with chronic bronchitis. The other option is in former smokers, you would consider using a macrolide as further exacerbations occur. So we can look at Geraldine's respiratory medications. We can see that she's on the Advair 550 as well as the Spiriva to manage her COPD. The Advair is a combination of a long-acting beta agonist with an inhaled corticosteroid, and then the Spiriva is the anticholinergic. The Advair is at the maximum dose available of 550. So following the guidelines, you can see she's already on a triple therapy. So she's already in the middle of the group D, which is highlighted in green. So there's really not too much we can change here. With further exacerbations, obviously we can progress up. She is a former smoker, so we could consider a macrolide, which in this particular case is would be like a zithromycin, which is readily available, fairly inexpensive. Geraldine uses Hannaford Pharmacy, which, looking at GoodRx, a prescription for azithromycin costs a little more than $10. So fairly inexpensive. Is that something we want to do for her right now? Well, I'm not so sure. She's not having an acute exacerbation. She seems to be managing okay with this. But what about her other medications? Could they be causing some of her problems and exacerbations? So I took some time, went into the interaction of Hippocrates and put in her current medications. I was surprised to find that Advair has a caution advisory with metoprolol, which it can decrease the effect of the metoprolol can cause decrease the bronchodilating effects of Advair and cause some bronchospasms, which for someone like Geraldine with COPD could cause a potential exacerbation of her symptoms. And then you can also see that there's a monitor and modify treatment for aspirin and with lisinopril and as well as metoprolol, both of her blood pressure medications. So looking at lisinopril, we know it's an ACE inhibitor, and from what we learned in class, it can cause a cough or a chronic cough and should probably be changed. So are her blood pressure medications causing further problems with her COPD? Possibly. Is there a way for us to tell right now? Not from our current findings with the exam or anything like that. We can certainly try making adjustments or eliminating lisinopril out of her treatment for her blood pressure. But that would involve possibly having to add different medications to try and manage her hypertension. Or we could just totally switch all of her antihypertensives to something different that might be suitable. So metoprolol is not a frontline antihypertensive. Lisinopril could be used as an antihypertensive initially, but following the hypertension guidelines, they recommend starting out with a thiazide or an ACE or an ARB, one medication, and titrating from there. You can also do a combination of two. So we could look at switching to something else. But I went in and also looked at if we were to switch her to a thiazide type diuretic for her hypertension, that there's a cautionary or a modified treatment advisory for an interaction between the aspirin and hydrochlorothiazide, as well as for the Advair and hydrochlorothiazide. I chose hydrochlorothiazide because it is a relatively inexpensive medication. It's on the $5 list for Hannaford Pharmacy, so it would be very inexpensive for Geraldine for if we were to start her on this. But the caution here with Advair and HCTZ is that it can potentially cause some hypokalemia. So there's a concern for possible renal function and lower levels of potassium. So obviously we'd need to monitor for her potassium levels if we were to make this change. So obviously there needs to be a discussion with Geraldine to try and figure out what's best for her. So what do we want to recommend for Geraldine? Well, talking with her and having the discussion about the blood pressure medicine, she's really uneasy about making any changes to her blood pressure medicine as of right now. She understands that the lisinopril could be causing some effects on her cough and causing further problems with the COPD, as well as the metoprolol not allowing the Advair to fully work on any constriction that she has in her lungs. So she understands that, but she still feels a little uneasy with switching to something different where we'll have to keep a closer eye on her potassium and everything. So she wants to sit tight with her current medications as far as that goes. So what are we going to do for her? Well, we want to ensure that she's properly using her inhalers. We want to make sure that she's getting the full dose every time she uses her inhaler. So we'll make sure that we review that with her and have her, we'll reinforce it and do a little teach back to ensure that she fully understands how to properly use these inhalers. We're going to recommend the vaccinations for both flu and pneumococcal. In Geraldine's case, it'll be the PCV13 to start. They both can be administered to her here while she's in the office. We're also going to set up a consult with pulmonology. Given the advancement of her symptoms and where we currently are in the treatment, I think it's best that we get the specialist involved if they can have any modifications to her current treatments to better manage her COPD. Discussing the pulmonary rehabilitation program with Geraldine. She's very intrigued and eager to learn better ways to manage her symptoms. So looking locally, New England Rehabilitation Hospital does offer an outpatient pulmonary rehab program. And the graphic on the slide is the actual flyer provided by New England Rehab. And they maximize patients' independence by providing a minimum of 2 therapies that help educate them on breathing exercises, balancing daily activity with breaks and rests, monitoring and managing their symptoms, use of medications. They also provide them with endurance and strengthening exercises as well as maintenance exercises, and also have ongoing monthly support group. The program is 8 weeks long. They meet twice a week. It is each session can typically last several hours, so it is some changes to Geraldine's lifestyle that she would have to make to ensure that she's able to make these sessions every week. And discussing with her, she is willing to make some changes in her schedule and everything she can attend these because she's very eager to get the education to better manage her COPD and the symptoms that she has. These are the references that I used to create this presentation. Hope you enjoyed, and I look forward to answering any questions that you have on the discussion board. Thank you very much.